everyone. It's my pleasure to be with you today. My name is Lauren Heinecke, and I'm an assistant professor of pharmacotherapy at the University of Maryland School of Pharmacy. And today we're going to be talking about part 3 of our antibiotic series from head to toe. Part 3 goes over pneumonia. We're talking about HAP, CAP, and everything in between. Our objectives by the end of our time together are that first you should be able to define each of the different types of pneumonia, including community-acquired pneumonia, hospital-acquired pneumonia, ventilator-associated pneumonia, and healthcare-associated pneumonia. And I have each of the acronyms associated with those pneumonias listed up there as well for you. These definitions are really the key in terms of really moving on to our next objectives to be able to identify the most common organisms seen in each of these types of pneumonias. And then certainly we know in order to be able to select empiric antibiotic therapy, identifying the most common organisms seen in particular infections is what leads us to select that empiric antibiotic therapy. So I think each of these objectives really ties into each other, and hopefully by the end of the presentation you'll feel really very comfortable with how to determine which type of pneumonia your patient has and what the most appropriate course of treatment is going to be for them. I think this next slide sort of sums up the way I, and probably many people, feel about pneumonia. It's CAP versus HAP versus VAP versus HCAP. You've got too many acronyms and not enough time. In fact, we've got plenty of time, so we're going to get right to it, leading into our definition slide. And I think our definition slide really sets us up, as I mentioned in the objectives, for the rest of our talk. So community-acquired pneumonia, you'll notice, is the last definition that we're going to talk about, because I think if you understand the other definitions, CAP really encompasses everybody else. So hospital-acquired pneumonia is pneumonia that occurs 24 hours or more after admission, and that infection was not incubating at the time of admission. So you weren't suspecting pneumonia when the person came in, but 24 hours or more after they've been admitted, they start to develop signs and symptoms of pneumonia, which we'll talk about in a couple of slides. Ventilator-associated pneumonia, so the person would be hospitalized, but they at this point need to be intubated. And it's considered ventilator-associated when it occurs 48 to 72 hours after the patient has been intubated. So if it occurs before this, we're talking then about hospital-acquired pneumonia. So the time frame of when it develops relative to when the patient is admitted, relative to when they're intubated, is huge in terms of determining what type of pneumonia they have and what bugs are most likely. Healthcare-associated pneumonia, or HCAP, is any patient who was hospitalized within 90 days of the current infection. They reside in a nursing home or a long-term care facility. They have received recent IV antibiotic therapy, chemotherapy, or wound care within the past 30 days of the current infection, or they've attended a hospital or HD clinic within the last 30 days of the current infection. So there's a lot of I think, important pieces that go into healthcare-associated pneumonia, and I think you'll find that if you really think about it, there's a lot of people that are admitted to the hospital that actually are healthcare-associated pneumonia and not community-acquired pneumonia. So then if you understand HAP, VAP, and HCAP, if they've got none of the things listed for each of those definitions, then they've got your garden variety community-acquired pneumonia. So community-acquired pneumonia is essentially everyone else. Before we can move on to talking about numbers, and those of you who have been part of my talks in the past know that I like numbers because I think numbers help us to think about how important a disease state is for us to understand, we have one more definition to talk about, and it's early onset versus late onset HAP and VAP. So I think that's an important thing to determine. Essentially, onset is a very important epidemiologic variable and risk factors for specific pathogens as well as outcomes in patients with HAP and VAP. So as you can imagine, early onset really carries a better prognosis, and actually these patients are more likely to have bacteria causing their infection that's likely to be antibiotic sensitive. And so if the infection occurs within the first 4 days of hospitalization, it's considered early onset HAP or VAP. Patients who develop their pneumonia after this 4-day window have a much higher risk of mortality associated with the infection, and they're much more likely to have a pneumonia that's caused by a multi-drug resistant pathogen. So in addition to the timing definitions we talked about on the previous slide, knowing whether it's early onset or late onset also is going to help you in terms of determining how important some specific multi-drug resistant coverage is going to be for your patient. Now that we have some definitions under our belt, I think it's important, as I mentioned earlier, to talk about the numbers. How important is this? Well, pneumonia overall really accounts for quite a bit of healthcare use. It is estimated to account for 1.1 million hospitalizations annually. The average length of stay for a patient with pneumonia is 5.2 days, which is a relatively lengthy period of time. To sort of separate things out a little bit, probably the majority of the hospitalizations we have reported are actually community-acquired pneumonia. So it's estimated that every year there are over 900,000 episodes of CAP in adults who are over the age of 65. So when we talk about our age groups in terms of who's most susceptible, we're talking about people over the age of 65. And what's interesting is that despite our advances in antimicrobial therapy, our mortality for pneumonia really hasn't changed significantly since penicillin became routinely available. So the mortality you can see up there, it's about 50,000 deaths annually. This is 2010 data. And about 3.4% of our inpatient hospital deaths actually are due to pneumonia. So we've talked about average length of stay is about 5.2 days. It actually is a bit longer for patients that have hospital-acquired pneumonia. Generally, hospital-acquired pneumonia increases the hospital length of stay on average by 7 to 9 days per patient. And this accounts for a cost of more than $40,000 per patient. So there's a significant amount of cost associated with this. And as you can imagine, a ventilator increases the risk for developing pneumonia. It increases the risk for developing pneumonia by between 6 and 20-fold. So avoiding mechanical ventilation, if possible, is certainly an important piece for preventing pneumonia. So I think the numbers really speak for themselves. There's a lot of people hospitalized. It's an important infectious disease for us to be familiar with and to be able to treat. We'll talk just very briefly about the pathophysiology. Really, it's the proliferation of microbial pathogens within the alveoli of the lung after you have an event occur. So aspiration is notorious for leading to pneumonia, inhalation of contaminated droplets, and certainly important sources are healthcare devices or the environment. You can have a hematogenous spread, which is the infection originates elsewhere in the body and then is spread to the lungs via the blood. You can have contiguous spreading. Contiguous spread is essentially spread from an adjacent organ or infected area in the body. Ultimately, once you have this infection occur within the alveoli, you have an inflammatory response. You have various interleukins and TNF-alpha, which lead to fever. You have chemokines that are released as part of the inflammatory response, which leads to your peripheral leukocytosis, as well as purulent secretions. And then there are inflammatory mediators that can lead to alveolar capillary leak. So lots of different things going on that can essentially lead to all the different inflammatory response that we see within pneumonia. In addition to taking a look at our numbers, and so recognizing that the majority of our patients who are coming in with community-acquired pneumonia are over the age of 65, I think it's important to just briefly talk about risk factors. We'll talk about them for CAP as well as HAP and VAP, and that's really sort of how they're separated if you take a look at the guidelines. So patients that are at greater risk for community-acquired pneumonia are those who have alcoholism, have a history of asthma, are immunosuppressed, are institutionalized, and it's sort of interesting that this risk factor is included here because, as we've already discussed, if the patient resides in a long-term care facility or a nursing home, you'd actually treat them as healthcare-associated pneumonia, not community-acquired pneumonia, and age over 70. So the older the person, the greater their risk for community-acquired pneumonia. For HAP and VAP, there are some specific risk factors. So intubation is increases the risk for pneumonia we talked about by about 6 to 20-fold, and that would really potentially lead to VAP depending on when the pneumonia showed up after they were intubated. Supine positioning, so the position of the bed is important. Supine position specifically increases the risk for the development of pneumonia. Hyperglycemia can increase the patient's risk for developing infection. It's interesting, stress ulcer prophylaxis actually has been associated with increased risk for developing pneumonia. And so I think we frequently talk about, as pharmacists, whether or not the patient actually needs the proton pump inhibitor or the H2 blocker. And certainly we know that intubated patients are at higher risk for stress ulcers. But if you have someone who's not intubated, I think really thinking about, do they need the PPI? Do they need the H2 blocker? What they've actually shown is that sucralfate has the lowest risk of developing pneumonia associated with it in one particular study. Now that we have an understanding of our risk factors, we understand our definitions, and we've got some numbers to really help us with how important this disease state is, let's move on to the etiology. What are the bugs that are associated with our different types of pneumonia? So specifically for community-acquired pneumonia on this slide, there are some differences in patients who are able to be treated outpatient versus inpatient. So the outpatient treated patients, and we'll talk about severity of illness scores and whether or not the patient could be treated as an outpatient or an inpatient in just a couple of slides. But the bugs primarily associated with those who have less severe pneumonia are Streptococcus pneumoniae, Mycoplasma pneumoniae, Haemophilus influenzae, Chlamydophila pneumoniae, and respiratory viruses. Now, the reason that Mycoplasma pneumoniae and Chlamydophila pneumoniae are highlighted in that gold color is because these are your atypicals. So I think a lot of times we'll say we need some good coverage for strep pneumo and H flu, and then we need atypical coverage. Well, when we talk about what our atypicals are, these are two of our primary atypicals. Patients who, based on their severity of illness score, will need to be treated as an inpatient are primarily infected with the following bugs. So they have generally potentially a more severe pneumonia. So strep pneumo can also cause more severe pneumonia. Mycoplasma pneumoniae can also cause a more severe pneumonia. Chlamydophila pneumoniae and H flu as well. So all of those are bugs that you saw previously on outpatient treatment. Legionella species generally cause a more severe pneumonia, so those are up there as well. Staphylococcus aureus and gram-negative bacilli can be involved in community-acquired pneumonia, although I would say these are not your typical bugs. And one of the things that I've highlighted is that the items that are starred with just one asterisk, so strep pneumo and H flu, can be seen in inpatient ICU and non-ICU patients, as well as Legionella. And then inpatient ICU only is where you could see your Staphylococcus aureus and your gram-negative bacilli. Now, one of the times where I think Staphylococcus aureus is more common in terms of being a cause of pneumonia is in a patient who has a post-viral pneumonia. Staph aureus is notorious for causing a post-viral pneumonia. So you might want to think about Staph aureus if you have someone who's recently had an upper respiratory or lower respiratory infection with a virus. In terms of thinking about HAP, VAP, and HCAP, these actually are going to have relatively similar bugs. So even though we have different definitions in terms of which specific pneumonia someone has, we're going to think about similar bugs and similar coverage. So they're rarely caused by viruses or fungus in a patient who's immunocompetent. So in terms of bacterial infections, we're going to think more about aerobic gram-negative bacilli now. We're getting away from our strep pneumo and our H flu, and now we're thinking about things like Pseudomonas aeruginosa and E. coli. We're also thinking about Klebsiella pneumoniae and Acinetobacter species. So some bugs that I know specifically at our hospital we would think about more resistance to. We've also seen an increase in the number of gram-positive cocci, specifically with Staphylococcus aureus, and I've already mentioned that really one of the times that this is more common is as a post-viral pneumonia. So one of the things I think that's really important to just talk about very briefly here is that in terms of thinking about empiric therapy, we're going to talk about lots of different empiric therapy that you can use, but when you think about differentiating between which antibiotic you'd be more likely to use, I think it's very important to know what types of multidrug resistant pathogens you have in your hospital. So they really vary by hospital, by patient population, and really by exposure to antibiotics. So it's really important for you to locally look at your antibiograms in your specific institution if you're in a hospital. And if you work in an outpatient setting, hopefully you can get a sense as to what the local resistant patterns are, and to make sure that the antibiotics your patients are coming out on sort of make sense for what you see generally. And it would probably be helpful if the local hospitals in your area are willing to divulge their antibiograms, just to kind of take a look at those. Although you would hope that it's been tailored based on cultures if they've gotten them. So really the most important item when you think about the bacterial pathogens that are causing HAP, VAP, and HCAP, and when we talk about empiric therapy, the most important thing to think about is the surveillance, and to be aware of the surveillance that's done in your area around antibiotic susceptibility, and to know the antibiograms. In terms of making a diagnosis, there are subjective as well as objective data that really go into our diagnosis. Subjectively, patients will complain of a cough, as well as fever, sputum production, and pleuritic chest pain. And certainly if you've got a patient that's intubated, you would maybe not have as much of the subjective data available, but you definitely have objective data available. So if they have a decline in their oxygenation, they're requiring additional oxygen if they're on a nasal cannula, if they're requiring additional higher levels of or higher percentage of FiO2, if they're intubated, they've developed a leukocytosis, you would go on to consider doing a chest x-ray. And when you do the chest x-ray, you're looking for, in the report, to talk about infiltrates. On physical exam, you may hear the physician talk about rails. You can look at their pulse oximetry and so see if their percentage saturation is going down. They may be tachypnic, so breathing faster. They may be tachycardic. Their heart may be beating faster to account for the infection. They can have diminished breath sounds on auscultation. They may also have crackles present. But really the thing that you're looking for to get the diagnosis is the chest x-ray showing the infiltrates. So I thought it would be helpful if on this slide I specifically showed you a chest x-ray, and you've got the classic radiology arrow sign that is showing you the infiltrate on this particular slide. The last part about talking about our diagnosis is additional testing. So I think it's important to differentiate that if you have someone with community-acquired pneumonia, additional testing is not necessary unless they require ICU admission or have one of those other specific indications. Specific additional testing can include blood cultures, sputum cultures, Legionella urine antigen testing, pneumococcal urine antigen testing. You can do an endotracheal aspirate or a bronchoalveolar lavage, or BAL as it's abbreviated, in someone who is intubated. And in someone who has VAP or HAP, everyone with VAP should get blood cultures. And everyone who has some version of HAP, so HAP, hospital-associated pneumonia, or VAP, really we'd want to get a lower respiratory tract secretion. And so if you don't have the ability to get an ET aspirate or a BAL, you'd want to try to get a lower respiratory sputum culture, which is more difficult to do than you would think. But for those patients, because of the risk of multi-drug resistant pathogens and the recommendations for empiric therapy, these are patients that you really want to know what's growing to be able to tailor their therapy and determine their length of therapy. So as I mentioned, there are some specific indications. Really, these indications are more thinking about your community-acquired pneumonia patients, because you're going to get additional testing with your patients who have VAP, HAP, or healthcare-associated pneumonia. So if your CAP patient has to be admitted to the ICU because their pneumonia is that severe, you would want to do blood cultures as well as get some lower respiratory tract secretions. If they've had outpatient antibiotic failure, if they have cavitary infiltrates or leukopenia, patients with active alcohol abuse who are at increased risk for multi-drug resistant bacteria, chronic liver disease, severe obstructive lung disease, as well as asplenia and recent travel. So things that predispose people for other pathogens, maybe that aren't on our etiology slides, and things that would predispose patients to more multi-drug resistant pathogens where we'd want to really broaden our coverage or know that our antibiotics that we're using are really treating the infection adequately. So we've got a lot of really great, important baseline knowledge under our belt. I think the next important thing for us to talk about before we get into talking about treatment is thinking about site of care decisions for patients with community-acquired pneumonia. So the decision to admit a patient for the treatment of CAP is the most costly decision that you can make, because the treatment of inpatient community-acquired pneumonia is 25 times greater than that of outpatient care, and it really is the driver for the majority of the money that we spend on treatment for community-acquired pneumonia. It really is about $8.4 to $10 billion that we spend on pneumonia. So we have three potential places that we could treat someone with community-acquired pneumonia. We could treat them as an outpatient, which is definitely going to be our least costly option. We could treat them in a hospital in a general internal medicine ward, which is where I practice, or we could treat them in the hospital in an intensive care unit, which is going to be our most expensive option. So how do we determine the severity of illness and what level of care a patient is most likely to need? There's a couple of different scoring systems. There's probably even more that have been cropping up, but the two that are probably most common in the literature are the CURB-65 score and the PSI, or Pneumonia Severity Index. So the CURB-65 is the one that's really preferred because it's the most simple to use. The PSI scoring system we'll go over in just a couple of slides, and it's significantly more difficult to do. I don't think I could remember that. CURB-65 I can remember. So CURB is an acronym, of course. C stands for confusion, U stands for uremia, and specifically it's a blood urea nitrogen greater than 19. R is respiratory rate greater than 30. B is blood pressure. It's a systolic blood pressure less than 90 or a diastolic less than 60. So we're looking for relative hypotension. And then 65. If you're 65 years of age or older, that gets you a point too. So each of these things that are present get the patient 1 point. And so what they found is that patients who have a CURB-65 score of 2 or greater are at increased risk for death, and these are the patients that should be considered for hospitalization. Certainly, as you get a CURB-65 score that's 3 or above, then you're going to start considering whether or not the patient needs to go into the ICU. So it still, I think, is a clinical decision, but in general what they found is that 2 or greater increased risk for death and really needs to be hospitalized. But if you have a CURB-65 score of 0 or 1, it's likely that these are patients that could be treated in an outpatient setting. So just to be all-encompassing, I've included the PSI severity scoring system. As I've mentioned, this is significantly more complicated, and I'm sure these slides are a bit difficult to read because the words are relatively small. So you've got a patient with community-acquired pneumonia, and then you go through this algorithm. Is the patient more than 50 or less than 50? And then you would go through various scoring systems, which is then on the next slide. So you also take into account coexisting conditions, and then you also take into account lab as well as physical examination abnormalities. That helps to determine where the patient should be treated. I think the next slide is really significantly more helpful, but you're going to use this algorithm in combination with this scoring system. So you get various points assigned based on demographic factors, coexisting illnesses, physical examination findings, as well as laboratory and radiographic findings. So once you've determined your score, you then put people in different risk classes from 2 to 5. So if their score is less than 70, they're risk class 2. If they're 71 to 90, they're risk class 3. 91 to 130, risk class 4. And 130 and above, they're risk class 5. So then you take your risk class, and that determines how to treat patients. So risk class 1, we wouldn't even get to using our PSI scoring system. If essentially if somebody is under the age of 50 and doesn't have any of the comorbidities, really you would assign them as, and doesn't have any of the abnormalities, you would assign them to risk class 2. So if you do get to the risk class scoring system, the way you, and the risk class 1 can be sent with home with oral antibiotics. Risk class 2 and 3, they can either be sent home with antibiotics or treated and monitored for 24 hours in the hospital. So these are probably patients that are going to have the similar CURB-65 score of 2 and above. And then patients with the higher risk classes 4 and 5, they really need to be hospitalized for treatment. So 2 and 3, you could potentially think about sending them home, but you would likely admit them and at least monitor them for 24 hours. And again, there is some clinical decision making that comes into play as well. So you can see that the PSI scoring system is significantly more difficult to use, although I will tell you the AHRQ, if you just Google PSI scoring system, they have an automated one that you can do online. I think CURB-65 just works just as well. There are a few different criteria to determine if someone has severe CAP. And if someone has severe CAP, then this is somebody who really needs to be treated in an ICU setting. So there are minor criteria and major criteria. If someone has one of the major criteria, that automatically buys them ICU stay. And I think they'll make sense if they're intubated or they have septic shock with the need for vasopressors, they need to be treated in an ICU. It makes sense. We don't do mechanical ventilation or vasopressors on the floor. Now, if they have three of the minor criteria, this would also be a reason for them to go to the ICU. So that includes a respiratory rate greater than or equal to 30, a PaO2 to FiO2 ratio less than or equal to 250. They have multilobe or infiltrates, confusion or disorientation, uremia, defined as a BUN greater than 20, leukopenia, as well as thrombocytopenia, hypothermia, or hypotension requiring aggressive fluid resuscitation. So 3 minor criteria also buy you admission to the ICU. So we've got a lot of really great knowledge under our belt, and I think it's probably about time that we get to use a little bit of it with a poll question. So I'm going to give you a case. It's the case of PF, who's a 72-year-old African-American female. She presents to the emergency department with a chief complaint of cough productive of yellowish sputum over the last 72 hours. She lives at home with her husband and reports no significant past medical history, no recent antibiotic use, no recent hospitalizations either. Her vital signs are as listed. Blood pressure is 110/72, heart rate of 86, and a respiratory rate of 20. Her temperature is 37 degrees Celsius. Her basic metabolic panel, I'll just highlight that her BUN is 11, since that's probably the most important thing that you want to know from a laboratory standpoint. So you've used your knowledge, you've put it to good use, and you've determined that she's fine for outpatient treatment. I think the next important part is what are we going to use to treat her? What antibiotics do we have in our arsenal to appropriately treat these patients? So I'll start out with just some non-pharmacologic and supportive care types of things. So certain patients may need humidified oxygen for their hypoxia. They may also require bronchodilators just to help with their breathing. Chest physiotherapy can be very helpful. Many times these patients come in and they're dehydrated. That is what contributes to their hypotension as well as their tachycardia, so hydration may be an important part of this. And if they have a fever, control of their pyrexia is also an important part of our, well, it's going to be pharmacologic actually, but more supportive care, not actually treating the pneumonia itself. So we're coming down the home stretch and we're getting into the meat and potatoes, the antibiotic management, so specifically talking about the medications we care about. So the way I've broken these down is by type of pneumonia, and community-acquired pneumonia specifically is broken down by where you decide to treat the patient. So if the patient has a severity of illness score that allows you to treat them as an outpatient, these are the antibiotics you're going to consider using. So it's basically broken down by whether or not the patient is previously healthy on the left-hand side of the slide, or if they have comorbidities or recent antibiotic use on the right-hand side. So if you've got a previously healthy patient, you could consider using a macrolide or doxycycline by themselves. Your macrolides that you have available to you are azithromycin, clarithromycin, and erythromycin. Now, when I think about using a macrolide, azithromycin is the one that generally is my default. Clarithromycin is twice a day, whereas azithro is once a day, so I'm likely to get better compliance with a once-a-day drug. And then with erythromycin, you have some significant GI side effects, so azithromycin is really my macrolide of choice. Doxycycline is an okay choice as well, but it's again twice a day. And the big toxicity that I think of with doxycycline is the sun sensitivity or photosensitivity when you take this medication. Now, the next important thing to consider is your surveillance data and your susceptibility rates in your particular area. If you have a high rate of macrolide-resistant strep pneumo in your area, you would not want to use the above options, the macrolide or the doxycycline. You would then automatically go with a respiratory fluoroquinolone. We'll talk about what that means in this next column. So when we talk about patients who have comorbidities or recent antibiotic use, we have two options. We can use either a respiratory fluoroquinolone by itself, or we can use a beta-lactam medication in combination with a macrolide or doxycycline. So when we talk about respiratory fluoroquinolones, what does this mean? It doesn't mean that they get better penetration into the lungs. It simply means that these are the fluoroquinolones that cover Streptococcus pneumoniae. So the ciprofloxacin gets into the lungs, it just doesn't cover strep pneumo, which is why we would not use it for community-acquired pneumonia. So your options for respiratory fluoroquinolones are moxifloxacin, gemifloxacin, and levofloxacin. I don't have a preference one over the other. I think for the most part you're going with whatever's on the formulary inpatient or whatever's on the lowest tier medication on an outpatient basis for your patient. When we talk about beta-lactams plus macrolides or doxycycline, I have different beta-lactam medications that you could consider using. Your macrolides are really going to be the same as in your previously healthy category. And you have the macrolide coverage because this is what gets the atypical. So your beta-lactam does not cover the atypicals, whereas your respiratory fluoroquinolones will. So your beta-lactam options are high dose amoxicillin, amoxicillin clavulanate, so Augmentin. Ceftriaxone is listed in the guidelines. This is an intravenous third-generation cephalosporin. This would not be my go-to on an outpatient basis. I would really reach for one of the oral third-generation cephalosporins or second-generation cephalosporins. So cefpodoxime listed up there is your oral third-generation cephalosporin. Many of you are probably thinking, why don't I have Omnicef up there, which is the generic name is Ceftonir. And the reason is that Ceftonir is indicated for community-acquired pneumonia. It has that indication, but it actually does not get great strep pneumo coverage. This would not be my first choice. I would go with cefpodoxime over Ceftonir. And then cefuroxime is an oral second-generation cephalosporin. So those are your options for outpatient treatment of community-acquired pneumonia. Now, if you have a patient who needs to be admitted to the hospital, so they've got potentially a CURB 65 score of 2 or greater, we're not going to be able to use the macrolide as monotherapy. Essentially, we're going to stick with our outpatient therapy for our comorbidities or recent antibiotic use. Although generally, we'll start with an IV medication for at least the first 24 to 48 hours, at least until the person is improving. So again, you have options of respiratory fluoroquinolones. We've discussed those on the previous slide. Or you can use a beta-lactam plus a macrolide. So really our same choices for our outpatients with comorbidities or previous antibiotic use. Now you'll notice that I have intravenous cephalosporins listed. I have ampicillin up there. You could use something like Unison, ampicillin, Selbactam, plus the macrolide. I have ertapenem listed up there, and ertapenem wouldn't be my first choice. I really like ertapenem for intra-abdominal infections, and it's fine for community-acquired pneumonia. It just seems a bit more broad to me than our other options, but it certainly is included in the guidelines and something you could consider using depending on your resistance patterns. Now, if we have somebody who has community-acquired pneumonia and they're so sick that they need to be treated in an intensive care unit, remember we talked about the major and minor criteria for severe community-acquired pneumonia really requiring ICU level care. At this point, we're going to use a beta-lactam plus azithromycin or a respiratory fluoroquinolone, and so it really, again, looks exactly the same as our non-ICU patients, but they are broken down a bit differently than our community-acquired inpatient non-ICU patient. Someone who's got a penicillin allergy, we would go ahead and use as Trianam plus a respiratory fluoroquinolone again, because we do not want to make sure we miss that atypical coverage, which we're not going to get with our beta-lactam. So ICU, non-ICU are really essentially the same unless they have additional risk factors for multi-drug resistant bacteria, and at that point we're really probably thinking about them as an HCAP, HAP, or VAP person. Which brings us to our next slide. So HCAP, HAP, and VAP. What are our empiric antibiotics going to be for these patients? So there are 2 slides dedicated to the antibiotics we use to treat HCAP, HAP, and VAP. And so this first slide is the treatment recommendations in the guidelines for somebody that has no risk factors for multi-drug resistant pathogens. So this is potentially early onset disease, so something that has occurred within the first 4 days of hospital admission. And to be honest with you, I feel like, at least in my practice setting, it would be very rare that we would have an HCAP, a HAP, or a VAP that we would be able to just use one of these medications for. I feel like the majority of our patients, our resistant patterns are such that we would really need to go a bit more broad than this. But if your susceptibility patterns for your enteric gram-negative bacilli, so E. coli, Kleb, pneumo, Enterobacter species, Proteus, Serratia, those types of things are really pretty good to these agents. These are certainly fine agents to use empirically. So you can use any of these agents, so ceftriaxone, or levofloxacin or moxifloxacin, or ampicillin sulbactam, so Unicin, or ertapenem. Now, if you do have concerns for multi-drug resistant pathogens in your patient that has a diagnosis of HCAP, HAP, or VAP, these are the recommendations. So you can use an anti-pseudomonal cephalosporin, which includes cefepime or ceftazidime, or an anti-pseudomonal carbapenem, such as imipenem, meropenem, or doropenem, or a beta-lactamase inhibitor, which includes piperacillin tazobactam, plus an anti-pseudomonal fluoroquinolone, such as levofloxacin or ciprofloxacin, or an aminoglycoside, amikacin, gentamicin, tobramycin. And so, depending on which of those first three you choose, so those first three options are really for your enteric gram-negative bacilli. In addition, you want to make sure you have MRSA coverage. The recommendation for MRSA coverage is with either linezolid or vancomycin. Now, I want to specifically point out the medication that's not up here for the treatment of MRSA pneumonia is daptomycin. And the reason that daptomycin is not included as part of these recommendations is that daptomycin is actually inactivated by lung surfactants, and so it is ineffective in treating MRSA pneumonia. So it's an important tidbit, I think, to take away from this. So, and again, I think a lot of the decisions about which antibiotic to go with is based on formularies, and it's based on your resistance pattern. So if there's nothing else you take away from this, I think looking at your surveillance data and looking at your antibiogram, if you have that information available, is going to be really the key in terms of determining which is the best agent for these multi-drug resistant pathogens. So before we move on to finish up the presentation, I really would be remiss if I didn't mention the most recent antibiotic that was approved, I think just in the last couple of years. That medication is ceftaroline, or Teflaro. And so I didn't include a specific slide on ceftaroline. I'm sure many of you are familiar with this agent, but these guidelines haven't been updated since 2005. And then the Community-Acquired Pneumonia guidelines, I think, were last updated in, I want to say 2007. But so ceftaroline was not on the market then. So ceftaroline was approved for the treatment of community-acquired pneumonia as well as for skin and soft tissue infections. And so ceftaroline, really, I think, claim to fame with ceftaroline is it gets MRSA coverage. So it's considered a fifth-generation cephalosporin. It does not cover Pseudomonas. It's not great for multi-drug resistant gram-negative bacilli, but it does cover MRSA. So it's not an unreasonable choice for community-acquired pneumonia. However, it is relatively expensive. I think the nice option for it is if you've got somebody who has a post-viral pneumonia and you're really concerned about covering for community-acquired pneumonia typical pathogens like strep pneumo, like H. flu, but you also are really wanting to get some MRSA coverage. So I think there's a niche for ceftaroline, but I wouldn't go wild with using ceftaroline. I think the other important thing to know about ceftaroline is that it is only an intravenous product. So it is not an oral product. It would not be useful on an outpatient basis. So take that for what you will. I wanted to at least mention it because I think it probably is going to be included in the updates of both of these guidelines. One of the updates should be out in 2014, the other one in 2015. I'm forgetting which one is going to be released when, but keep an eye out for those. And I think ceftaroline will probably make its way into those guidelines. Although probably doesn't have as great of a role in your HCAP, HAP, VAP patients, again, because it doesn't get those multi-drug resistant gram-negative bacilli. So in terms of your antibiotic duration, I've broken it down into community-acquired pneumonia, and then your HCAP, HAP, and VAP. So community-acquired pneumonia is a minimum of 5 days. The patient really should be afebrile for 48 to 72 hours with no more than one sign of clinical instability before the antibiotics are stopped. Generally, you're going to be treating for about 7 to 10 days, but certainly we want to minimize antibiotic exposure because of risks of superinfection such as C. diff, and certainly the adverse drug events with them are not something to minimize. So in terms of HCAP, HAP, and VAP, Again, you can do 7 days if you have a good clinical response. Now, if you've got Pseudomonas aeruginosa or you've got a slow initial response, you're probably going to extend that for somewhere between 14 and 21 days. So I think antibiotics are one of those things where we don't have perfect studies that tell us exactly what the duration is. In general, we're looking for clinical improvement before we stop our antibiotic therapy. So I've got some general minimums, minimum of, I'd say 5 days for CAP, 7 for HCAP, HAP, and VAP. Certainly think about extending that if your patient is slow to respond initially, or if they have something that's more difficult to treat, like Pseudomonas. So now we've got all of our treatment information under our belts, and so we'll move on to the second of our poll questions. So we're going to bring back the case of PF, who, if you remember, is our 72-year-old African-American female that we determined had a CURB 65 score of 1, and we were going to treat her as an outpatient. So this is the data, but I just refreshed your memory with respect to her CURB 65 score and our decision in terms of where we were going to treat her. D, azithromycin 500 milligrams PO times 1 dose, and then 250 on days 2 through 5. So the key here is thinking about whether you've got a lot of resistant strep pneumo to macrolides, and in that case you'd want to go with a fluoroquinolone. The cefodoxime by itself is not a great option because without your macrolide or your doxycycline, you miss that atypical coverage, which is something you want to make sure you're covering. So C really is not a great option. And levofloxacin, either one of those is not a bad choice. Either one of those would certainly be a fine choice. I think the key is just we're looking to minimize the broadness of the antibiotic we're exposing PF to. So levofloxacin is not a bad choice, but the best choice is azithromycin based on what I told you about the strep pneumo resistance in the area that PF is being treated in, as well as the fact that she does not have any comorbidities. So to finish us up, I'll just briefly mention prevention because you all know I do a lot of immunization talks, and so certainly vaccination can help in terms of preventing pneumonia in patients. The two biggest that have been shown to help decrease the rates of pneumonia in our over 65 group are both the influenza vaccine as well as the pneumococcal polysaccharide vaccine. And so there is going to be a new immunization talk, I believe, coming up soon, so that's something to look forward to. And then just to finish up, a quick summary of the information that we've covered today. So really the definitions are the key to identifying the most likely etiology, so determining the bugs that are most likely to cause your pneumonia, and then the most appropriate empiric antibiotic therapy. Again, I think the key is, again, to keep in mind, you want to look at your local resistance patterns, your local surveillance, and then also your local antibiogram, because that, again, is going to help you determine the most appropriate empiric antibiotic therapy based on your most likely pathogens. The severity of illness scores can help determine the most appropriate treatment setting for patients with CAP, and by treating patients in the outpatient setting, we can certainly decrease the amount that we're spending on the treatment of this infectious disease. Our antibiotic duration should really be guided by our response to therapy, with thinking about a minimum of 5 days for CAP and a minimum of 7 for HCAP, HAP, and VAP. And then finally, immunizations are an important preventive strategy.